For the next case, we have a 63-year-old lady, Ms. Lam, with past medical history of hepatitis B with concomitant fatty liver disease, MASLD. Fibroscan done, showing a LSM at 36.9 kilopascal and CAP at 334. OGD done this July, showing no esophageal varices or gastric varices. EUS-guided liver biopsy came back to be NASH, NAFLD activity score at 3, fibrosis stage 4. Patient is currently not on any non-selective beta blockers to prevent hepatic decompensation. She was referred to us for US PPGM to assess for clinically significant portal pressure. So Professor Chang will be demonstrating to us EUS plus PPG measurement commentated by Professor Shannon Chen and Professor T.T. Chen.
Hi, Ken. Shannon.
Hello, hello.
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 Morning.
Hello, good morning.
Hi, Philip.
Hi. So we learned about the case. So you are now starting the portal pressure measurement?
Yeah, so first I wanted to show you the images of the liver. Are you seeing the EUS?
Yes. We have the EUS video here, yes.
Okay, so now I'm imaging the left lobe of the liver, and the liver echotexture is slightly hyperechoic, which goes along with steatosis. I'm going to do a quick indentation here, palpation, and as I palpate, push, release, push. It's a stiff liver. It's less than 3.5 millimeters. So that's already showing me that this is likely a cirrhotic liver. Now we want to show you shear wave elastography. So Ting Ting's going to turn on the shear wave.
Yes.
And
Is this okay?
capture. So shear wave here is 26.
6.3.
Yeah, 26.3 kilopascals, which is quite elevated. And the CI, which is 99%, is the same as the VSM, which is the percent of the region of interest that has good data coming back. So 100% is perfect. 99 is pretty good, even for Asians. Okay. Okay. So the Asian parents want 100%.
Oh yes, that's good.
Okay. Let's do one more shear wave.
Okay, just a moment.
Capture.
Over here.
Yeah, 25.8. So very high stiffness. So next, we want to look around in terms of the liver anatomy. We also want to look to see if there's any gastric varices, any collateral vessels. So as we look here, we are seeing some gastric varices. So let's turn on the.
These varices were not seen on the previous.
Can we turn on the E-flow? Yeah. Okay.
So Shannon's mic is not so clear, so hopefully that they can adjust a little bit more.
So we are seeing some gastric varices, even though endoscopically they're not apparent, and there's no esophageal varices. You can turn that off.
Yeah.
So that tells us that she does have portal hypertension. Whether that's developed since the last exam or not, uncertain, but certainly she does have gastric varices. So now we're going to take a look at liver anatomy, and let's get the pointer. Is this the?
Here.
Okay. All right. So this is the left hepatic vein, and that separates liver segment 2 from liver segment 3. And then as I rotate to my right, that's the left portal vein where the arrow is. The left portal vein is identified by the thicker, more hyperechoic wall, and it's tethered on the left by the ligamentum teres, and it's on the right is the ligamentum venosum. So this is the ligamentum teres here, this right, and then ligamentum venosum will be on this side right here. So we have ligamentum venosum, ligamentum teres identifying the left portal vein, and that would make this segment 1 and this segment 4. Now we're going to follow we're going to follow the left hepatic vein towards the IVC. So I'm pulling my scope back while following that left hepatic vein. That's over there, and I'm pulling back, pulling back, pulling back, pulling back. Okay, so now I'm going to rotate to my right, and we're going to see here. Let's see here.
Yeah, IVC.
Yeah, so that's the IVC, where the arrow is. And then you can see the right hepatic vein coming into the IVC. Just if you can move the cursor to the left a little bit. Yeah, a little bit left and down a little bit. Yeah, right there. So that's where the right hepatic vein is. And then if I rotate a little bit to my left, we should be able to see the middle. There's the middle hepatic vein, that long vein right there. That's the middle hepatic vein, which creates the appearance of an elephant head and the elephant trunk. Elephant trunk is the middle hepatic vein. So we have the middle hepatic vein, and then I rotate to the left, and that's the left hepatic vein. So the middle hepatic vein separates segments 4 and 8. So to the left of the vein is segment 4. To the right of the vein is segment 8. And then the right hepatic vein separates 8 from 7. Segment 7 is the most posterior. So that's how we identify all the liver lobes. Over to the left is the main portal vein. If you move the cursor all the way to the left, that big vein, that's the main portal vein. So, so now the question is, you know, which vessel should we target for portal pressure measurement? Is there still meaningful value in getting a portal pressure measurement? We see gastric varices, so we know the patient has portal hypertension. Does knowing the actual gradient help us and inform us? So I'd like to hear what the panel thinks.
Well, Kenneth, if I remember correctly, if the portal pressure is less than 12 millimeter mercury, there won't be much risk of bleeding from the varices. But you are measuring different branches of the portal vein. Would the pressure in the main portal vein be different from, you know, the smaller branches? And what is the, I mean, as you said, this patient already developed varices. What is the additional information that you can get by probing into the vessels?
Yeah, so these are all really important questions. The measurement of the pressure within the main portal vein and the left or the right portal vein, if it's reasonably close to the takeoff, within 2 to 3 centimeters, has the same pressure. But if you go way out into the periphery, where now these vessels are, you know, 2, 3, 4 millimeters in diameter, then the pressure may not be the same. So we do rely on accessing the left portal vein right where that it's the umbilical portion of the left portal vein, and that is exactly the same as the main portal vein. On the hepatic vein side, essentially we want to be able to measure the IVC pressure. So we could target the IVC, but that's a little bit more risky because typically you're not putting your needle through liver, and the device is not on label for IVC. It is on label for the hepatic vein. So the hepatic veins, typically we target the middle hepatic vein, but in this case, that middle hepatic vein may be a little bit too steep of an angle. By the time the needle enters, we may or may not be able to get it, although right now it's a possibility. The right hepatic vein is rarely ever targeted because the right hepatic vein is coming off the main IVC, and you have to hit the IVC, and plus those varices are right there. And then the third option is the left hepatic vein, which is here, and that is also a possibility, maybe over here.
I also have a crazy idea. So, like you can outline the vasculature so clearly by endoscopic ultrasound. Is it possible in the future to do tips through EUS?
Yeah, so we've done in animals tips. all you need to do is find an image like this. Let me show you. Where you see portal vein, and then if you see hepatic vein next to it, then you simply put a stent across both and bridge them. So it is possible to do endoscopic tips, like here, there may be an opportunity right here between those vessels up there. But, you know, because of sterility and so on, I don't think that's going to be something that will go to clinical because the transjugular is done so well and sterilely. So it's feasible, but the infection issue is still an issue. So getting back to the question is, for this patient, is it of value to her? So it's not a value in determining if she has portal hypertension. It may be of value if we establish and quantify the degree of portal hypertension at baseline now, and then put her on a non-selective beta blocker, and then repeat. One of the nice things about this technique is you can do serial, you know, once a year or whatever, you can do serial measurements to make sure that your beta blocker dosage is actually significantly lowering the portal pressure below danger, below 12 or 10. If we can lower her portal pressure down to 7 or 6, then that's the right dose, because our conventional way of titrating the non-selective beta blocker is systolic blood pressure, pulse, or orthostatic symptoms, which is only a surrogate indirect reflection of the true portal pressure. So that would be of value. So we could do that, or if clinically it's not going to make a difference, then we don't need to.
So in fact, I think our center is currently running a trial to correlate the use of beta blocker with the recurrent varicose bleeding. So for all patients with hepatitis, with a cirrhosis-induced varicose bleed, we band it first, and then we measure the portal pressure, and then we prescribe beta blockers, and repeat the portal pressure in 3 months, and to see if the beta blocker actually makes any difference. So hopefully, it's in line with Professor Chang's idea of using this as a parameter to titrate the beta blocker. So maybe we'll have more evidence by the end of next year.
So I think given all the considerations, I think the left hepatic vein is the reasonable one to target. It is slightly smaller diameter. However, the angle is good, and there are no gastric varices in the path of the needle.
So does it matter which vein to puncture first, like portal vein first or hepatic vein first?
It doesn't really matter. I like to get hepatic vein first because that establishes my base. And then once I have that, then my first measurement on the portal side, I'll know the gradient. So it's just a matter of, do you like to go up and then down, or down and then up? I like to go down and then up, but it doesn't really matter. Yeah. And then if you're suspecting, you know, right heart failure as the etiology for portal hypertension, and your hepatic vein is over 20, 25, then that also helps.
Yeah.
Okay. So we're going to now put the 25 gauge needle.
So for the patient position, is there a particular position that you would like to put the patient in?
Yeah, we usually like to put the patient flat on their back. That way we can properly place the transducer in the mid-axillary line. So
does it always have to be under MAC? Can it be under IV sedation?
yeah, typically, especially if we're doing liver biopsy also, then we like deeper sedation, either MAC or general. But if all we're doing is portal pressure and the patient's well sedated, IV is okay. But again, we want to make sure the patient is, you know, very, very still.
So Professor Chang, will you also give prophylactic antibiotics like before this procedure?
Yes. For this patient, because she's cirrhotic and she's got varices, I would do third generation cephalosporin.
Thank you.
We can do pulse wave if we have time.
Yeah.
So the hepatic vein pulse wave, let me see if I can we make this more sensitive or? The pulse wave of the hepatic vein has 4 phases, A, S, V, and D, but we're having a little trouble with it right now. That's okay. Typically, I would confirm that, but let's see. I'm not getting a good signal.
Yeah, I think it's better.
Yeah, there it is.
Yeah, it's better.
Yeah, now we can see the pulse wave. Yeah, right there. Yep. Okay. That's good. Okay.
Good.
That's fine. All right. So now I'm ready to look at my trajectory. So I've, just like with any FNA, you want to line up the needle with the target. And here I'm going to, so my technique is actually through and through. I'm going to go through the vessel and then pull back to get it into the center. So I'm going to do a fast movement. I'm going to let her breathe and then go. And now I'm going to move back. And so when you're dealing with a small caliber vessel, this technique is very helpful because when you pull the needle and retract, it will actually open the vessel and make it larger. But if you go slowly against the front of the vessel and push, it'll collapse the vessel. So in this technique, you're opening the vessel. In the traditional technique, you close the vessel. So I'm going to just go slowly back up until I fall in, which is just about now. There. Okay. So let's go ahead and flush.
Okay, so now I'm flushing some saline.
Good. And I can see the microbubbles. And if you can read out the pressures.
So the pressure is now around 18 and 19.
Okay.
So
Is it stabilized?
Maybe we can
it's
zoom
dropping
in
a little bit.
to the manometer to show the reading to our audience.
Oh, it's 7, 8.
So now it's dropping to around 9 and 10.
Okay, 9. All right, so we take the lowest, stable,
so usually,
so
how
it's
long
9.
do you wait?
About 30 seconds.
Okay.
So this is good. Let's flush it again.
Okay. I'm flushing it again.
Perfect. We saw some microbubbles. That's great. And again, we're going to wait for it to stabilize.
So it's difficult for us to zoom in, I guess, but I think we trust the measurement that it's very interesting. So you wait for 30 seconds to stabilize. So the reason is, what's the reason?
Because when we flush the needle, the pressure will go up because of the flush. And then we just wait for things to equilibrate so that the needle, the pressure in the vessel is now transmitted through the entire needle and back to the transducer.
I see.
Okay.
So now
So
it's
we'll
at
get a
14.
second value of 14. Okay, so let's do another one.
So
Okay,
would
that's
you
good.
do several measurement and then take the average?
Yeah, so what we do is we want to get 3 consecutive measurements that we feel is reliable. So if we get quite a bit of variability, we'll continue until we get 3 consecutive that are close together.
So what are the common reasons that the values vary?
Yeah, for example, a bubble in the needle can do that. So now we're getting 15. All right, let's flush again.
Okay.
Okay, that's good. And
I'll flush it again.
okay, good. Now we're getting yeah, the vessel is small, so the needle can wind up, moving. So what are we getting now?
16,
16.
15.
15. Okay, so we have 15 and 15.
And 14.
And 14. So 15 and 15 and 14, which is pretty reasonable. So now I'm going to pull the needle back. And I'm going to stop here and look for flow in the needle tract. And I'm going to rotate left and right just to make sure there's no flow in the needle tract. There's no flow. There's no flow. There's no flow. Okay, so now I'm going to take the needle out. And we can turn the E-flow off. And then now I'm just going to rotate to my right and identify the left portal vein, which is right here. All right, so if you can hold the scope right there for me. Yeah, a little bit right there. Perfect. Okay, so now that's the right portal vein. And here's my throw. And I'm going to pull the needle back into the portal vein, and it's right there. Okay, it's flush. Good.
So it's 22.
Okay.
I'll flush it again. So you mentioned if you can't find the middle hepatic vein, the other options is the left hepatic vein and the IVC.
Right.
So if you can't access the portal vein from the stomach, are there other options of puncturing the portal vein?
Yeah. You can puncture the portal vein from the duodenum. Typically the right portal vein you can get with some liver.
So it's 23 now.
Okay. Flush again.
Okay. Ken and Shannon, thank you so much. I think this is a wonderful demonstration, especially when you are puncturing different caliber of the vein, and we can see the technological difficulty, and also you've done it so well and outstanding. That's the difference. So we have another room ready, so we have to start the next case. So thank you very much for a nice demonstration. Thank you.